Welcome to the Science of Fitness podcast, where we aim to inspire you to live a more healthy and fulfilling life as we share evidence and anecdotes on all things relating to health, performance, business, and wellness. Welcome back, ladies and gentlemen, to the Science of Fitness podcast. Very exciting guest, Dr Conrad Makrikanis. How are you, mate?
Good, mate. Thank you.
Thank you for jumping on. Just ploughed through a session. I think you're probably, the first medically trained doctor on the podcast with us. I might have offended someone in saying that, but very excited about this, mate. Very quickly, give us a brief introduction. What do you do? Where do you do it? How long have you done it?
Yep, so I'm an anaesthetist working at predominantly Greenslopes Hospital now, so all private, and encompass a broad range of surgical specialties. So this afternoon I'm doing 3 Caesars. Yesterday we were playing orthopedics, doing joints. The day before, fixing people's bowels, do a lot of eyes, still do urology, so cover a broad spectrum. And that's the beauty of anaesthesia. You really touch upon a lot of different surgical specialties. A long medical history. Started in science as a field biologist. Went through the back door, did my honours and got through medicine when I was undergrad. And went bush, got a rural scholarship, went bush for a couple of years and loved it, especially with a biological background. So I spent the next 15 years working in remote communities, a lot of Indigenous work, specialised in Indigenous health. We're in Broome for 7 years. The nearest referral centre was Perth at 2,500 kilometres. Oh, wow. So you package people up, stuck them in the plane. We do a lot of medical evacuation and retrieval, so it was awesome. And you're doing everything from ED with neonates to old folk, delivering kids, doing anaesthetics. But that's a young person's game. And we had 3 kids, and then we went back to Cairns. And anaesthesia in Australia is a 5-year training program, regardless of what you've done beforehand.
Wow. So
it's a slog. Getting on is very difficult. There's 2 big exams. One's the physiology and pharmacology. So we're in medicine, we know most about those 2 areas, which gives us a great advantage, when we're doing our practice. And then the second exam is incorporating pathology, surgeries, and the outcomes of giving anaesthetic, obviously, in the outcomes. And so now anaesthesia incorporates the prehab component, so pre-op work, the intra-op work where you're putting people to sleep, looking after them, managing, and then the post-op, which is managing pain and extreme physiology sort of events. The exams in anaesthesia are shit. So there's 2 exams. They're 1,000 hours each of study, which is full-time work plus 20 hours a week for a year, and you do that twice. So that's the real entry point and exit point. So, we do a lot of work, and we're probably the most unknown, talked about specialty. So in 2016, they interviewed 3,000 Australians. 16% recognised as specialist. Another 25 recognised as doctors, and the others just didn't know. And that's bad on our behalf because no one really, you don't meet an anaesthetist very long. Yeah. And there's not much publicity about it. Yeah. But we're really, we're running the theatre, looking after people while they're unconscious and at high risk. And then ideally you're optimising them pre-op, and then you're looking after them post-op. And there's all variations in that. So super interesting specialty. It's been a long journey. It's funny that assumption is,
I met my anaesthetist. He spoke to me for 2 minutes, and then that's it. It's the easiest job in the world. It must have a wonderful work-life balance. We'll talk about that.
We will talk about that. Boom, boom.
Right. Before we get into the nuts and bolts, the person behind the practitioner. So we've been doing it with a few guests.
Yeah.
First question: if you could improve one thing in the world, what would it be and why? As it stands today for you?
Yeah, I think it would be to ask and demand health specialists to talk about obesity. Because I came from a general medicine background and into anaesthesia, sadly in Australia by 2030, so in a few years' time, 50% of our population will be obese. At the moment, it's 75% are either obese or overweight.
75%?
Either. So it's based on BMIs, right? So BMI is body mass index. It's not perfect, but it's great. And it's your weight over your height squared. And it's supposed to correlate to what percentage of your body is of adipose tissue or fat. So I think, people get really caught up in the cosmetics of obesity and the negative tropes. If you're fat, you're, hopeless and lazy and blah, blah. which clearly is a very significant, emotional. People's self-esteem is low. But from a medical perspective, it's a disaster. There's a list of what obesity causes. So the WHO did do a 10-year review, came out a month ago. Leading cause of global cancers is smoking at 20%. Obesity comes in at 15%.
Wow.
So I'm sure people don't recognise that aspect. Alcohol's about 7%. So the cancer causes breast, colon, ovary, endometrial. There's all the metabolic stuff which people are much more aware of. So the increased risk of diabetes. You die of heart attacks, strokes, kidney disease. It's the leading cause of liver transplant. So non-alcoholic liver, fatty liver disease, NAFLD. Yep. And then there's the joint stuff, so increased arthritis, especially pelvis and knees. There's gut disease, so increased gut, reflux, gallstones, just doesn't stop.
And this keeps going, yeah.
So I would be, there's the other side of that coin is the first time ever in our history there's a drug that specifically deals with it. Now, the big question is, why has obesity become such an issue? So evolutionary wise, it's a great strategy for our body to store energy when we need it. Historically, we've never been surrounded by so much food. You get food everywhere.
Food and comfort.
Food and comfort, right?
Stillness,
everywhere.
Not moving.
And in the 70s, the obesity epidemic started, where 75% in the 70s worked outside, and now 75% work inside.
Wow.
So people are just inactive, and food's definitely become more dense. So the combo of fat, sugar, and salt. And unfortunately, there's this great divide between low socio and high socio, where in the old days, as you know from Africa, if you're wealthy, you're fat.
Yes.
Because you showed your wealth by eating more, and everyone else was skinny. So it's the opposite now. So the poorer you are, the fatter you are, because you have access to cheap foods, which are disgusting.
Yeah. The economics I'm finding probably the most interesting thing. I mean, now it's one of the leading causes of death in Samoa.
Yeah.
And not a developed nation by any means, yet exactly as you're saying, they have now this access to this mass-produced, highly processed, cheap food.
So Samoa's interesting. I worked there a couple of years ago. Biggest people in my life I've ever seen.
And they're innately genetically
exactly. So there's
there's
a Samoan fat gene now. So 40% of Samoans have this gene.
Yep.
So when they jumped on the boat and paddled as Lapita people, if you had the fat gene, you stored more energy and you could make the journey. So it was an advantage.
So that's the theoretical model as to why it's
the thrifty theory.
Stayed. Wow.
And so now
that's
it's just
why
working in
they're
there.
Good at footy as well.
Yeah, exactly. They're big and fast and strong.
Is it a fat gene or is it a synthesis gene in its own right?
That specifically is fat gene. So they've shown that 40% of morbidly obese Samoans have this gene.
Okay, wow.
Firing off. It stores fat.
Yeah, right. That's interesting.
Very effectively.
Yeah, which is, as you said, for tens and thousands of years, our entire evolution made a ton of sense. Yeah. Until the last 30.
Yeah,
20,
so
20 in this case.
Since the 70s, Samoans later. But, you think, so it's been 50 years, this evolutionary sort of epidemic of obesity. Our genes have not changed, right? It's not a genetic problem. So people have tried to blame epigenetics, but it's not a genetic thing. It's just we now live in a lipogenic society, so a fat-gaining society.
Yeah.
So it's actually difficult to exercise. Like you guys are in a bubble here. There's not much obesity here, right?
No.
Everyone's motivated, tend to be quite young, 30s and 40s, maybe 20s, and they're
adhere. They
managing their health.
They identify psychologically with exercise
exactly.
in the gym. And, he's the fit guy in the office.
Yeah, but now that's unusual. Like when you even compare working in a public hospital, private hospital, public hospital. Wow, if you go and work in Logan, the average BMI is 30-35 average. And then it goes up from there. Like it's just insane. It's become such a common thing that people's, So the average weight of a male in the 70s was 70 kilo. That 70 show? Everyone's skinny, right?
Yeah.
And now it's 92 is the average weight. So in 50 years, we've put on 20 kilos as a society.
Jesus.
It's just awesome. But the other side of the coin, there's GLP agonists, which you've heard of, Ozempic, Wegovy, Mounjaro. I'm the greatest advocate of the drug. I see obesity as a chronic disease now. It's not a cosmetic problem.
Okay.
The surgeries for obesity, gastric sleeves, gastric bypass are a disaster. gastric sleeve, you can eat through your sleeve in about 3 years. So you'll lose 20, 30, 40 kilos and put it back on. And then once you have a gastric bypass where they detour the plumbing of your stomach to dump food straight in your intestine, you get all these complications.
Yeah.
So, for people who are, super morbidly obese, they definitely help. But these new injections, and there's 20 GLP agonists. So GLP stands for glucagon-like peptides.
Yeah.
It's a natural occurring hormone, right, in your body. It's glucagon-like because that's the peptide that sits there and it's cut up into different versions. So you get 20 versions of it.
Okay.
So when you inject it, you get 1,000 times of your natural occurring dose.
Interesting.
And it suppresses your appetite. The food noise goes. The satiety increases. So you only eat a certain amount of food and all of a sudden you feel that you're full.
You're full and you stay full.
And your gut slows down. So that's the side effects. The reason we give a shit about anaesthesia is because you're increased risk of aspirating, where your food contents goes into your lung. So we became experts about the drug very quickly.
You had to, yeah.
Because of the risk of aspirations.
Okay, so then the layman listening to this that goes, oh, but what about the gut health? Or they've listened to some 15-second Instagram clip of someone spruiking that this could be a risk to their stomach.
And it's early days, been around 10 years. All I would say is that the risks associated with being obese far outweighs some of these other aspects that we talk about.
That are potential risks.
There's
we
potential
don't even
risks,
understand if they genuinely are.
So I think it will upset the microbiome, and the microbiome is a big deal. I'm sure you've talked about microbiome before, which is the colony of bacteria that lives in your gut, but also on your skin everywhere. We haven't worked out what the microbiome does medically yet. It's clearly probably a responsibility for these early cancers we're getting. But let's get people's weight down first, and then we'll talk about it. That would be my perspective.
Yeah. And, when people do bang on, gut health is going to be at risk with it. Well, it's probably already at risk being obese, being overweight, and the consumption of certain foods that got you there have probably, I won't say wrecked your gut health. It's hard to actually definitively say that, but it's probably had an influence on it.
For sure. And look, I'm not trying to minimise the impact of an individual who's carrying extra weight. Like it's, you see staff at hospitals, a lot of the doctors are on it now, and a lot of nursing staff are on it, GLPs.
Yeah.
And, and I am intrigued by their journey. I love it as a, just a human sort of experience. And you go and talk to some of these staff and they're like, a doctor I've worked here for 20 years and a surgeon's never spoken to me. And for the last year, people are so, I appear in the room for the first time.
Wow.
I'm a person. And you're like, holy shit. So the impacts are massive. Carrying weight in this society is difficult for sure. But these drugs are expensive. There's 20 more on the market. There's a new one coming out next year, retirdotide. It's 30% weight loss. There's a new tablet coming out, so rather than injectable. So it's probably, if you see increased blood pressure causes stroke and heart failure and heart attack, you take an antihypertensive for your life. Diabetes is where insulin can't efficiently store sugar. Sugar goes up, you're associated with blindness, heart attack, whatever. You take antibiotics for the rest of your life. This will be a rest of your life tablet or injection.
You reckon?
Yeah, for sure.
Interesting. Do we know if people are getting on it, coming off it, they're gaining that weight back?
Yes, they definitely gain the weight back.
Okay.
Yeah, about 3/4 of the weight's gained back. So if you're on the drug, it's not a miracle drug in that I just take it and I'm done. Lean body weight is lost as same as adipose tissue. So lean body weight's bone and muscle. And and this place knows that muscle has now become the biggest organ in our body, regulates all sorts of shit, not just locomotion, but, sugar control, lipid control, mood, or, a whole bunch of things. So if you're on a GLP agonist, you have to start resistance training twice a week, and you just go slow because it's a long game. So you do a little bit and you build more. I highly recommend seeing, you guys XFizz. Since you guys got a provider number, there's more XFizz on the block than I've ever seen in my life.
Yeah.
And you have to increase your protein intake to preserve your muscle mass.
Which is hard when you don't feel like eating.
That's right. So you must go to a nutritionist. Be the recommendation, and you should see XFizz. And look, this is all cost, but you've got to value, what's the cost of your life and what's the cost of a good life.
Yeah.
And you get all that by looking after yourself.
Yeah, absolutely. Okay, well that's a small thing we could improve.
That's right.
One major life lesson you've learned or experienced in the last 12 months, good or bad?
One thing that's been annoying me lately is this idea of a work-life balance. shits me big time. Ericsson showed you need 10,000 hours to be good at something. And it's very in these years where you're having kids and trying to buy a home and doing your job, you just got to work hard. Like if you want to be good at something. And so what I've gained, so how do you deal with the work-life balance? It's very difficult, right? Like now my life is balanced per se, because I'm 57, I've done the hard years. The kids are now left school and I'm no longer on call, 30 years on call. So I can spend time doing this sort of stuff. But from your work here, this idea of, the hot cold baths where you put yourself in extremis.
Yep.
And the Wim breathing where you put yourself extremis. This idea of going hard where you have to go hard, be efficient. And when you're off, go off going hard.
Okay.
Wind down, find mechanisms to wind down well and be aware. Don't leave things to chance. Program it in, do it properly.
In what context of, okay, I'm programming in some off time? Yeah,
off time. Yeah, programming off time. Brooks talks about those 4 values of being happy, faith-based, whether it be philosophy or not. Your family, your friends, and a job that's provides a purpose to yourself and you're servicing others. So to do those things, you just got to program it in, dude. You just got to do it well. Go hard when you can, switch off when you can.
I think it's an important thing for young people to understand is programming the off, because it's, we have a lot of young people around us as clients and our team's young. It's very hard to go home and turn off when you turn on to any one of the myriad of devices available to distract us. But they often pull you not necessarily into your work, but into something that probably relates to your work.
Yeah.
I can go on my phone any one time. Someone's training, someone's writing programs, someone's giving health advice, and my head's going to be in there going, I agree, I don't agree. And it sort of feels from a cognitive load perspective, I'm still on. Yeah. And then to close it and to open the freaking book and read this thing recreationally just for the sake of it and enjoy it, it's invaluable, and even just sitting still, we've spoken about it a lot, just literally just sitting and just being still, going for a walk or going for a surf. The conscious, deliberate programming of it is, I think, what we now need to be. And again, it's an area as a species I think we've stumbled into unintentionally.
Yeah, I agree, yeah.
For a lot of time, we would walk to and from work. Mate, I was thinking, I was reflecting, you can probably talk about this a bit more. We used to get paid by a check and walk to the bank and have to cash that thing in, every fortnight, every month?
Every fortnight, yeah.
That doesn't happen anymore. All those little incidental moments of maybe activity or maybe just boredom and downtime are gone. And it's exhausting. So now we need to, just like we need to consciously not choose to eat that food that the ingrained evolution is in us to be really conscious and clear.
And the devices really muddy all the waters, So I'm trying to, I put the phone in the kitchen at night now. I've got a bedside clock. It's great.
Yeah.
Try and do those things. I think that if you can isolate the device, I think you're halfway there to a quieter mind.
And consciously observe your behaviours with it.
Yeah.
Because we're ingrained not to have to do that, but suddenly we're here. Yeah. Interesting. Rightio, let's dive into it. So, first and foremost, I really want to dive into the evolution of medicine and healthcare.
Mm-hmm.
In this nature of we've evolved into these circumstances, and it's not, I don't believe there's any one evil group of people with a staff in the ground going, ha ha, look at the rest of them, we're going to make fun of them. I feel like there's quite often a narrative sold, particularly on the internet, that they want you, big pharma, this, that, the other. And it makes people kind of neurotic about all this sort of stuff.
Yeah.
But are we moving to more of a preventative model as opposed to, being reactive, or is it just a nice idea to think that? I live in a bubble.
Yeah, totally. You're in a bubble. Like the P2Ts of this world, that's a big, expensive bubble. The general health that I see, no one's doing it. Even if you look at there's about 300 billion spent on health per year in Australia. Something like 2 to 3% on preventative health.
Wow.
It is not there.
Okay.
And the idea that we're, doing health checks and we're, this whole longevity sort of scene, to me, even amongst my colleagues who are, well-versed in health, with great medical literacy, there's only a handful doing it. And amongst patients, if I find one who's doing it, I celebrate and chat to them for 10 minutes before the operation sort of thing. So, it's a bubble. It really is a bubble, sadly. People are just, in crisis mode most of the time. they seek healthcare when they're in trouble, in terms of health, illness-wise. There is the occasional person that's, like even it's funny, the guidelines that the Australians release about what we should eat, how we should sleep and how much exercise. If you look at the data, 15% people follow it. 15%.
Jesus.
It's just craziness. Yeah. So I think, this preventative health idea, it's, as the individual, I'd promote anyone to go and get regular health checks, GP-wise, but things are getting expensive. Yeah, it's difficult.
It is.
Yeah, but I think the basic things still stand, right? Sleep well, eat well, exercise, be happy.
Yeah. Well, that's what I was going to say. What's, in your opinion, low barriers of entry?
The preventative, so the general practice is the cornerstone of our health system. And unfortunately, they had poor bastards. I mean, I was a GP for years, not desktop GP, but 2010 they did a freeze on Medicare until 2022. So for 12 years they got the same payment. And then from that time, the out-of-pocket expense went from $20 to now average $50 to go and see someone. So it's all just became, it's just become muddied and more difficult. But if you go to a decent GP who's a good communicator, they'll tell you what you need to do in terms of screening for various, in Australia, you start as a kid, you got your infections and trauma, and then teenagers is drug and mental health, and then there's a pause for a while, and then it's chronic disease, and then cancer. That's the normal progression of our life. Yeah, where chronic disease takes up 80% of the health budget. Like, it's the big deal. So if you can stop that in the 30s, age 40 is when shit starts happening. The early cancers pop up, people have sudden death, and that's when chronic disease starts.
Yep.
So if you can get in and be proactive about, looking at what your cholesterol is, checking your blood pressure, doing these basic things, and don't see going on medicine as being a negative. The agents we use these days, most of them have gone through pretty rigorous testing, randomized controlled trials. You got to watch out for drug company sponsored stuff. There's definitely some bias there, but now there's a lot of systematic reviews that pile all the evidence together and come out with some reasonable sort of ideas. And that's where we're a well-trained medical society. And if you go and get some decent advice, you can, if you go on a lipid-lowering agent, you will lower your chance of having a stroke or heart attack. Mm. So I don't see it as being, I hate when people say, oh, I'm in this drug, I hate it, sort of thing. Because you'll live longer and better.
Totally.
And if you chuck some, throw some exercise in, a couple of resistance training sessions a week and maybe a couple of aerobic sessions a week, you're on top of the game with anyone else. So I think that's the low threshold in, is that classic, sleep well, try to eat well and do some exercise, like literally.
And so in your experience of a range of diverse communities, Indigenous health, you've worked in Samoa, for example, developing countries, private centres. How has that sort of shaped your view on good healthcare?
It's the same thing. I will. So the Indigenous stuff is super interesting. It is overall Indigenous health is improving because blackfellas are going into the cities rather than staying in the bush. Okay. The communities are disasters, absolute disasters. This is a great one. If you compare Kew suburb in Melbourne, which is the healthiest postcode in Australia, to Alice Springs, which is the worst health code in Australia, there's a difference of 30 years of life expectancy.
Wow.
So there's a whole generation lost by being an Indigenous person living in Alice Springs.
And the lifestyle effects on those.
Take that.
Having your grandparents help you look after the kids.
All of it. So they, that classic trajectory I talked about, where you have infection, trauma, and mental health and whatever. I nearly started a PhD in Indigenous health. Thank God I didn't. But the mums aren't well nourished to start with. There's some grog and alcohol stuff goes on. This is by no means across. There are now a whole bunch of medical, there's Indigenous doctors, lawyers. So there's now a much more diverse range of the Indigenous individual in Australia. So you can't generalise it all. But in this compressed lifestyle, you get this overlap of there's a burden of disease early on. So infection, a lot more infections, a lot more trauma. They start getting chronic disease at age 15 and they're getting cancers in their 30s. It is insane. So we, working there was, it was great in terms of medical experience, but it's so tragic. Like, it's so tragic.
do we understand why?
Yeah, it's a lot of it, like colonisation definitely had a big impact in that just, in Queensland, 1890, the state government auctioned communities to the churches, created 13 communities like Yarrabah and Cherbourg and Doomadgee, those places, and auctioned them to the churches to take control of this what they thought was going to be a dying race. And so they split men and women. They wouldn't allow language being practiced. Traditional practices were abolished, and kids stolen. And that, I mean, it's a very real event. It's not just something the government sort of goes on about. We moved to WA to Broome. They didn't have that same system. So up there, the pastoralists had big bodies of land, would let a clan of 50 or 150 people live on their land, practice culturally, have 4 or 5 languages, be able to, this idea that they're not a wandering race, they're not nomads, they're very distinct cultural groups. There's 400 to 500 languages in Australia, languages as separate as European languages.
Yeah.
And we saw in Broome, the middle class in Broome was Indigenous. Like, it was such a relief to see that, it's not all the same across Australia.
That's very interesting.
Very interesting. And so very difficult to generalise, but the combination of being a black minority in a white dominant society, the colonial effects are massive. Translocation, dispossession of land and place, huge. And just when your parents, like the biggest predictor of how an Indigenous person is going to, the outcomes is where their parents worked. And so there's this gross chronicity of generational unemployment. And you can see that in the white side as well. A poor white person is suffering big time. Their education standards are lower and just choices are shit. And their life options are limited.
Yeah.
And that's just magnified Indigenous stuff.
Yeah, wow. It's something that I found very interesting moving here, whenever years ago it was, about 17 years ago, culturally, is having lived in Africa where you've seen it, it's so culturally rich. And
it's beautiful.
The tribal nature of that place is actually frightening but beautiful in its own right. But there's 6 or 7 major different African black cultures in South Africa alone. Yeah. And you move here and there's Indigenous and that's it, and you sort of go, well, you don't learn anything else. You don't learn the language, you don't celebrate the culture, you don't understand that there's 400-500 languages. I mean, that's the first time I've heard of it, and that's my ignorance. I haven't opened the book or read or listened or looked. But yeah, I mean, it's fascinating. Then there's that state to state contrast as well. And
in New Guinea is the same, 400 languages there, separate ones. They're the same sort of peoples. 60,000 years been pretty much established now. People compare the Indigenous Australians to Maoris, New Zealand Kiwi Maoris, completely different. One language group. They're only there 500-600 years ago. Culturally, similar. I'm not related to my studies aren't in Maoris, but you can't make that comparison. Yep. And they did a treaty with the Brits, 1800s, 1850s. Very different scenario. Yeah. So I think one of the reasons that the blackfellas here can't get their shit together is because there's so many different cultural groups. There's no one voice. First and foremost. Yeah. There's no one language. So it makes it very
different. Then all the colonial.
All the shit, yeah. Layers upon layers upon layers. Yeah, exactly.
Yeah, it's very interesting.
So I don't know what the original question was.
No, it's just that sort of understanding about diversity and how it has shaped your opinion of good healthcare. And I think we've already touched on it. I sit here in this wonderful, unique 99.9th percentile of health, and I form my opinions on, we need to look at, bone density a little bit more for women and that sort of thing. And I'm a little bit worried about your muscle mass or your DEXA scan. And yet here we are, looking at it in Australia, in Indigenous societies and even just lower socioeconomic societies in general. It's quite interesting. And, for me, my head goes to how can we dive in and solve those problems? Yeah. And it's not a one.
I thought education would be the, growing up, as a lefty, I thought education would solve everything, but clearly not. And it has to be a combination. Work is a real thing that drives a lot of self-confidence and motivation. And so, it's multi-layered. Things are definitely improving, though. I think, if you listen to, everyone's made to feel guilty about their existence in this country. Yeah. Which is, it's obviously a balance, but things are improving for sure.
Yeah, and I think
for the individual,
for me is It is exciting. I like to sort of look at these things with a degree of excitement in terms of someone listening to this might find a lot of purpose, and I'm going to go and attempt to solve that problem or contribute to it. It's really funny
just
from
don't,
a health perspective.
Yeah, don't go and think you know the answers, that's for sure. We still go out to Longreach a couple of times a year to do eyes, cataracts mainly, and we do Indigenous eye lists here on a Saturday, like 3 or 4 times a year. And there's a service that a bus goes around and picks up a whole bunch of folks from the Goldie out to Cherbourg, all the way up to Gympie actually, and brings them to one place, then takes them home at night.
Wow.
And we use a system now in aesthetics called the ASA, which is the American Surgical Association. So if you're 1, you're fit and healthy, doing great. If you're 6, you're ready to give your organs up for transplant. So as the number goes up, your health status deteriorates. So typically people would be 2s, maybe 3s. If I'm doing cataracts, which are 50 plus years old.
In urban.
In white Australian Brisbane
Central
urban dwellers.
Brisbane, yeah.
And we did a list 2 weeks ago. 30 eyes, the 3 or 4s they were, in terms of just your average bloke. People missing limbs, missing organs, just shit life. Just one guy just came out of ICU a few days prior. Rang him up saying, "Are you okay for your eye thing?" Yes. He get in there and he said, "My resting SATs, which is the peg you put on your finger, is 88. I've got 20% of my lung function. And if you give me oxygen, I'll die because my respiratory system's so crap that I rely on oxygen levels, not CO2 levels," which we aren't. It's like, you wouldn't get an operation anywhere in the world here, dude. Let's do it. Let's get your eyes going.
Let's go.
Because we know that giving people their vision, is the cheapest and most effective operation you can have.
Interesting.
So he came back for his second one. He's smiling, still abusive, still swearing at everyone.
Yeah.
You can see he was pretty happy.
Oh,
pretty
that's
funny.
unreal.
It's pretty cool.
It's so interesting. Let's stay on that sort of rating scale, and I guess the preparedness. You mentioned anaesthetics deeply involved in the preoperative optimization.
Yeah.
Do you think specialists within medicine will increasingly become part of that preventative ecosystem in that sort of sense? As we understand, the more we mitigate for risk, the better the outcomes are going to be? Yeah,
it's in terms of surgery, right, specifically, publicly the anaesthetists run all the pre-op stuff. And it depends. It's a stupid system. So a patient comes to a surgeon. They book a surgery based on your category. So category 1's urgent, has to be done within a month, and then it goes backward from there, 2, 3. So if you talk to people in public, going in public, for a knee replacement, say, they might be waiting for a year or so before they get called in public. So you'd think that as an anaesthetist, I would see them and then have a year to work them up. But the system is not that organised. They get a date for their surgery a year later, a month coming up to it, and say, "Okay, go and see Conrad now in pre-op, 3 weeks before your operation." Because we can't let them go earlier because they may not get an operative date or things might change, or so it'd be a waste of resources. That's the perspective, right? So that means you've only got a short period of time to optimise somebody. And so when they come to our clinic, and that's anyone having an operation, we try and we identify what ongoing disease, what burden of health they've got, and try and optimise it. Is their asthma well managed? Do they still have chest pain? And then we'll send them off for tests. And then we give them a tick when they're ready for surgery. So the prehab stuff is pretty unique, like in terms of you need a motivated person with some assets to get places, to be able to do some physio for a couple of times a week. And we've shown that, especially in the older population who are weaker, that if you pre-optimise them for up to 6 weeks, they'll halve their complication rates by 50%.
Wow.
So I think to our audience here, the message is, the chance of having an operation is pretty high, right, at some stage. And surprise, surprise, you need to be in good form all the time.
Yeah.
So the time I think this is a nice topic. If you look at, I think Hannah was talking about nutrition the other day and metabolism. Yes. So if you look at your metabolic needs, 56% is basal metabolic rate, which is the amount of energy your body needs to stay alive. Just at rest, right? At rest. And everyone's blown away by that because you think that if you go and do an exercise for an hour, you'll be consuming most of your calories, which is bullshit, right? So 60% is basal metabolic rate. 5% is your energy required in eating. So the more whole foods you have, the more energy you expend, which is recommended. And then if you go for a run or do a session, you might spend 10, 15%. So the rest of it's this thing called NEAT, non-exercise activity thermogenesis. Now, when I used to talk to patients, and I'm a pain in the ass talking to patients about their exercise, I've had complaints about me to surgeons saying, I came to have my knee done, and this guy's just talking about how much I'm going out walking and what I'm, what exercise I'm doing. Neat, there's non-exercise stuff, is the steps you walk, the 7,000 steps, that's neat. In the garden, that's neat. Walking the dog, that's neat, right? So is it important? Yes, it is important because it reduces your metabolic risks, your vascular risks, which I elaborated on, and your immune health. So it actually reduces your risk in an operation. If you're 30% neat, you reduce your risk of clot, right? So because you're lying flat in a bed for a period of time and someone's operating on you, your inflammatory markers go up, your blood stays still, you increase the risk of a DVT, and then go to your lungs PE. You reduce your risk of wound breakdown, so improve wound healing.
Wow.
This is just neat.
This organic.
Yeah, this organic stuff, right? Just from moving, you improve your immune system and your insulin resistance goes down. So you're overall better. So that's this neat stuff. So doing that stuff is actually important. Stopping the bus stop, the one stop before you get to work, walking up 2 flights of stairs. I thought it was all bullshit, but it actually has a function.
Totally.
And it's been shown now, illustrated in surgery to reduce risk. And then if you actually focus on a cardiovascular system by doing the aerobic and strengthening, you reduce your major complications and you reduce your length of stay in hospital. So, I've been fit, I'm active lots and have been all my life, thank goodness, just good habit, enjoy it. A colleague of mine who's 5 years older, I had a aortic valve replaced a couple of years ago, lucky, streamed through, no complications. He got atrial fibrillation. He had a stroke. He's had wound infections. He's not an overweight. He's an active guy, but he's not super fit. He's quit anaesthesia because of it.
Jesus.
Yeah. Just, I think a lot of it is just, there's so many elements. There's luck involved. But statistically, if you do this stuff, your risks are lower.
And your luck increases.
Your luck increases, that's right. So, can we pre-optimize people beforehand? Yes, we can. But the overall story is, if you stay fit all the time, it just happens that if you have surgery, you'll do well. Yeah.
I mean, it checks out, makes sense. And that's what I was going to say when, back to developing countries, lower socioeconomic people, there is access to get off the bus, stop earlier, as simple as that is. It does go such a long way. I mean, I know for myself, I'm one of the lucky ones. I've got such an active job.
Yeah.
I'll average 15,000 steps a day.
Yeah.
And my big days, if I do a run or something, beforehand, it'll blow out to 22, 25,000 active. I don't actually get enough fuel in.
Yeah, that's right. That's a rare problem.
I'm just so lucky. But, I think of, the average person sitting listening to this, sitting watching something, sitting at work, not moving. And it's all well and good to come and do a HIIT class with us. I bang on about the mechanical effects of not moving, not active, not having a neat type exposure.
Yeah.
But it has effects on the way people move and generate force here.
Yeah, I mean, there's secondary and tertiary gain, all this stuff. But like for the sitting, for example, 70% sit at a desk. And so the recommendation for NEAT is that every 20 minutes you get up for 2 minutes and go for a walk. And that's enough to offset your sitting for 20 minutes.
Yeah, wow.
Like it's crazy.
Yeah.
It's actually crazy.
It's not complicated.
It's not complicated, but you get tied up and you sit there for hours and meanwhile your clot risk increases and your vascular health decreases. Like it's amazing.
Yeah.
It's crazy.
And I think, that's the other thing, and there's an extent of this on sleep is that you can kind of offset it. You do a 15, 30-minute walk into work. You take that extra little moment. You'll be able to afford to sit for that little bit longer in terms of actually on that equation. It doesn't need to be on 20 minutes.
Yeah, exactly.
And if it's not that, then you're done. It's manageable, and you can bookend sedentary periods really well. And I think that's the biggest thing for me. The funniest thing I find is people's energy levels, particularly when they come in here, particularly in the afternoon.
Yeah.
They are flat.
Yeah.
But by the time they finish, they've got more energy at 6 p.m. after a long day of work.
Yeah.
And they're like, yep, I feel good. They're happier. Their mood's better. There's obviously, plenty of neural, psychological and biochemical processes that drive that.
Yeah, totally, yeah.
Movement, motion gets things going.
Well, we're made to run. There's no question about that.
Yeah, made to move.
Yeah.
Let's dive in and speak to the 1% or the 3% because they're probably listening to this.
That's right, yeah.
with longevity being the motive, how do we navigate major medical procedures better? We've just spoken about generalized exercise, fitness and wellness. I've got this knee.
Yeah.
Seen multiple physios. At some point I'm going to get surgery. The surgeon said, hang in tight.
Yeah.
You got bone on bone, this, that, and the other. When the pain becomes unbearable,
Correct.
let me know.
Yeah.
What can someone do in that 1 year runway?
Yeah. So, knees, knees specifically, but it's going to be elaborated to all, the other joints and other things. Knees are all about quads, and you need to strengthen your quads as much as you possibly can. So the general terminology, the general sort of approach would be, see a physio or ex-phys beforehand. If someone says you need an operation at some stage, you engage with someone who has knowledge in that area. You say, radio, do with me what you will. Especially shoulder surgery, getting your supraspinatus going before a shoulder surgery has massive, impacts post-op. So you're doing the prehab stuff, so your post-op process is much more refined. If you're training your muscles to move beforehand, they will move better post-op for sure. You want to optimize your weight, ideally. So we talked about obesity before. Obesity or extra weight in surgery is a pain in the ass for us. Like, we see it medically. I can be very black and white about it because, we had a 190 kilo guy the other day having a bowel surgery. Normally it takes, 15, 20 minutes to get someone into surgery, get ready, put them to sleep, have the operation. So it's a two and a half hour process, the whole thing for bowel surgery. 5 hours this took. It took us an hour and a half to get ready. All the extra bits of the bed we had to put on. All their risks are increased: DVT, respiratory risk, aspiration, like it's everything. So you don't want to be in a catabolism. You don't want to break up your body in surgery and post-op. So you don't want to be
in an attempt to lose weight.
That's right.
Be prepped for surgery.
Exactly. So you don't want to be nutritionally poor, but you want to try and lose adiposity. And so the way to do that is nutritionalists, go and see a dietitian. And in that combo with physio and dietitian, you'll be all over it. And you really want to, for those things we said before about the NEAT and the strengthening and your cardiovascular fitness, you want to do that combo of 2 sessions of strengthening a week and 2 sessions of aerobic a week. Plus, if you need to sleep well, because that's where all your healing processes are, your rejuvenation. And you need the 8 hours so you can the first part of your sleep is for healing and the second part of the sleep is for your cognitive organisation. I'd stop alcohol, to be honest. Alcohol screws you to sleep big time, as if anyone wears a Whoop will know that. But also it's a fairly impressive immune suppressant for the bone marrow, even a couple a night. So remember the adage that was a hockey stick, where two glasses of red wine was good for you?
Yeah.
So I knew cardiologists back in the 90s who would deliberately drink wine because they thought from the data that it was good for them. They didn't like it, and they did it. And now the Brits have shown 30-year prospective study, every cigarette you knock off 20 minutes of your life, right? How's this? Every drink's 10 minutes of your life. Wow. So alcohol's poison. There's no question about it. It's very direct. There's no benefits alcohol long term. Clearly you get benefits socially and stuff here, but I would stop drinking. Smoking, vaping, pot, smoking a joint should stop. And you need at least 6 weeks for your lungs to recover from. So if you go in at 4 weeks, we would cancel surgery like 10, 15 years ago. If someone was a 20-pack smoker, so 20 a day, and we saw them for their operation in a month, we'd actually cancel the surgery in the day because that increases their risk of bronchial secretions. So you need a good 6 weeks to 8 weeks for your lungs to heal after smoking. And your lungs will heal, and then you'll actually have good lungs from then on. Yeah. Like if you've done damage, you'll do damage. But, it'll actually repair itself to a degree. Yeah. So the fags, grog, sleep, nutrition, and exercise. If you do those, you're swimming.
Yeah, and you're dealing with the big problems as well.
Yeah, that's right. Yeah.
Yeah. In terms of patients that navigate surgery exceptionally well and from those who don't, and I guess more in the psychological context of you deal with people there and then, as you said, three weeks out and you're going, oh, fuck. Mentally you're obviously trying to help people in their confidence.
It's a big part of it, actually. It's a big part of it. Meeting an anaesthetist beforehand is very beneficial, like that exchange you have by both calming, reassuring. Having medical literacy around your operation is super key for your brain, for your emotions. So if you're able to definitely ask questions to people who know, jump on AI, whatever you have to do, to get information around your surgery. And if you're, I'd recommend in private, if the anaesthetist doesn't make contact with you, I'll ring people if it's a major surgery these days, but I won't ring everyone. It's just too much work involved. Ring the anaesthetist was typically be associated with a practice, an anaesthetic practice. Ring the practice, ask them for him or her to ring you. And that's, if I speak to people on the phone the day before, a couple of days before, and then meet them on the day of, it's like we've been friends for weeks. It's a unusual experience actually, but very reassuring. Patients love it. Anxiety levels are now driving the community. Like it's the highest anxiety we've ever had historically. People don't know the causes. And it's a common problem preoperatively. People are coming in shitting themselves, pale, sweaty, the whole lot.
Which is going to have biochemical effects on
Well, you require more anesthesia, for example.
Wow.
And if you're anxious beforehand, you come out not fresh. Like you definitely suffer post-op as well.
Yeah, right.
Super interesting. And so how do you manage anxiety? There's all the stuff you guys do with your breathing and, so embedding some of those techniques pre-op is key. The information literacy, definitely having more information reduces anxiety. But you can actually request something like Valium.
Yeah.
And I do that for sure. I will do that to anyone who asks for it. If you're shitting yourself and it's really
overwhelming,
just ring up the anaesthetic office and say, can he give us a call and we can get some Valium. So you arrive, check in, have some Valium. I don't know if you've had Valium before. It's a lovely drug. It's a benzodiazepine. It works on GABA receptors in your brain, and that's the hyperpolarizing negative. So you just super chill. It's lovely, and you just the people are smiling, and and it makes the anaesthetic actually smoother. Ironically,
interesting.
Yeah.
In terms of the understanding of the risk profile of minor surgery versus major surgery for individuals, how often are you sort of communicating that? I guess what's the big misconception?
Yeah, so people, I think it's a really good question. People think, so anesthesia, I'll just talk about that for a second. So the anaesthetic day is 16th of October, 1846. That's when the first anaesthetic was given formally in the Ether Dome in Massachusetts, in Boston, Massachusetts. It was a big deal. So prior to that, people, there's been anaesthetic versions forever. The Greeks, a combination of opium, alcohol, mandrake, like in Harry Potter, which is anticholinergics. THC pot was used. So a whole bunch of things. But in terms, what's anesthesia? Anesthesia means an is the removal of, like anorexia, removal of appetite, anemia, removal of blood cells. Aesthesia is sensation. So aesthetics, right? So anesthesia is the removing of sensation. And when you break it down, it's a combination of reduced awareness or abolishment of awareness. We call it hypnosis, which is a drug-induced reversible state of deep sleep, and analgesia, which is removal of pain. So that's what anesthesia is, plus or minus paralysis. 1846, a demonstration was a guy gave ether, William Morton, to a guy having a vascular tumour cut out of their neck in the Ether Dome, which is like a theatre. That's why they call it theatre, because everyone used to watch.
Yeah.
And for the first time ever, it was demonstrated that you could actually... So ether, diethyl ether, which is a horrible agent, but it has all those three components. It has amnesia, analgesia, and hypnosis. It has all three, right? And so the patient got the neck cut up, sutured up, the gas was removed, he woke up and said, what's happening? And the classic thing is, this is no humbug, gentlemen. That was the statement made. But the drugs, so nitric oxide, ether, and chloroform had been around for some time, like 20 years beforehand. But the Christians wanted people to suffer. Like it was a classic, you will suffer if you have it. And so it changed. So people were having drug parties with nitrous specifically and ether, where they go to upper society, suck on this shit, and then be unconscious. And that's how they worked out, because one guy broke his leg but didn't feel it. And they were like, oh, actually, this shit could be used for anaesthetic.
Wow.
So it evolved. So all our agents have evolved from there. Australia, the first anaesthetic in Australia was given in in Launceston a year later. So it spread very quickly once it was released. Yeah. The Brits did chloroform, which is a different agent we don't use anymore. But modern anaesthesia now is an evolution from the ether days. And you think the Civil War, American Civil War, just came after that. and the American-Mexican War. So for the first time ever, the soldiers were getting anaesthetics for their amputations and whatever. So it really started surgery off. So now the problem is now that anaesthesia is so safe, right? The medicines are good, the monitoring is good, that now I'm doing 91-year-olds. I did 2 91-year-olds the other day because we can do that now. So operations become more complex. So in terms of risk, I think people either are clueless as to what risk means in anaesthesia. It's not a risk-free procedure. There's the anaesthesia and the surgery. They're both inflammatory components. And so we say there's common things like bruising, sore throat, nausea and vomiting, pain.
That's related to anaesthesia.
Well, and both, but yeah, we sort of anaesthesia. And, you will feel dizzy and you'll feel fatigued. And so we say they're all common things. They're what to expect. And then the uncommon things, aspiration, where your gastric content goes in your lung. So the uncommon things are life-threatening. Anaphylaxis, a reaction to a drug that causes swelling, histamine release and things. A cardiovascular event, respiratory event where your lungs just collapse. Death under anaesthesia is about the same as dying from jumping out of a plane with a parachute.
With a parachute, I was like...
That's right. So it's about 1 in 400,000. So the other thing people are scared shitless of, and rightly so, is awareness. So awareness is where there's implicit and explicit awareness. Explicit is where you're paralysed because of the anaesthetic. For some reason, the anaesthetic is worn off for whatever reason, and you remember everything that's going on. And that can, screw with your brain. People get PTSD, it's horrible. So that's something we focus on for everybody. So we've got a brain monitor to avoid that. Happens in about 1 in 20,000 cases. There's high-risk cases, there's a whole bunch of things. But for the average guy that we're talking to here, that risk is much lower than that. And then there's this stuff called implicit, where you don't remember anything, but you're sort of a bit screwed up for some reason. And if you actually go and see a cognitive behavioural therapist, you can come down and say, it was the time of the anaesthetic. And that's more common, actually. I had this similar experience, and it can be pretty weird. But overall, I think that's where we talk about common stuff, which is to be expected, pain, nausea, and vomiting, whatever, and then the uncommon stuff, which is rare. And it's based on how healthy the people are, what sort of surgery you're having, high risk surgery. And
that's what I was going to say. Is it minor surgery? I'm getting my wisdom teeth done versus major surgery.
Exactly.
Is an anaesthetic risk profile a little bit different?
Very, very different. Yeah, very different. Yeah. So it's very unusual to have a major complication in minor surgery. But what we'll do is, if you're having your teeth taken, for example, Wizzy's done, there'll be bleeding. So the risk of aspiration is high, and respiratory stuff is higher. Yeah. So that stuff we tailor while we're giving the anaesthetic. We put packs down the throat and we do all that stuff, and we make sure that doesn't happen. But it's more likely than that if you're going to have a urology where someone's sticking a scope, up into your bladder, for example. Yeah. Like those things are like. So it's very surgery specific. It's the wellness of the patient and therefore the age. And also it's elective versus emergency. And even emergency, the data is if you're having your NOF done, your neck of femur fracture fixed after midnight, your chance of death is pretty high.
Really?
Yeah. There's no resources, everyone's exhausted.
Yeah.
You know what I mean? That's shit, and we've all been there. Like we've all done that stuff.
Yeah. Yeah. I think that's an important thing, if you could have people, I guess, conceptually understand. Most of us are users. We will go in and have surgery and then walk out. From the medical perspective, what do you sort of wish people maybe understood or appreciated? Say post midnight, it's much harder to do these procedures because it's dependent on multiple people.
Yeah, totally. Yeah.
Is it is there something that you sort of think, geez, if society could conceptually understand what's going on here? Does something come to mind?
I think it's just this literacy idea. Just being more informed. If you're uncertain, ring people, talk to. Most people have got medical friends or can access them. ChatGPT is good. I think if the more informed you are, the better you are in terms of your approach. Yeah. And recognise there are risks involved there, even though they're low. So don't get pissed the night before and come in for your surgery, which happens. Yeah. And book some time off for after the surgery because you're not going to bounce back straight away. Okay. Yeah. So take it seriously. But the chances that you'll get through with a good result is quite high. But not all surgery is perfect. And most of the time, orthopedic-wise, for example, you come out, you never go back to what you originally were.
Yeah, that's a big thing for people to understand.
Huge,
particularly the later stage surgeries. I'm finding with the knee replacements, the ACLs for people north of 60, and meniscus issues and shoulders, and if you can do something to prevent it, do it, and if you're going to have it, do everything you can to mitigate its
agree.
effect on the whole wash up from a movement perspective.
Yeah, you're not like you were before the injury occurred, but you're better than you were after the injury occurred.
Yeah.
So it's worth having
in terms of
done.
pain
and
comfort,
mobility. Yeah,
mobility
exactly.
day to day.
Yeah.
Mentally, I think it's the biggest thing.
Yeah, exactly. You
pain,
can keep going.
Musculoskeletal pain particularly just wrecks people. Peter Attia, we've spoken about a lot, had this sort of idea that he floated maybe a year or two ago, where he talked about, do we age in this gradual sequential process, or does it happen in one big hit like a major surgery?
Yeah.
We can all probably think of a grandparent or an uncle or auntie that had that surgery and never were quite the same, and they never quite got back to full strength. What's your opinion on that?
Oh, the data is pretty clear that you don't deteriorate slowly once there's a major event. So even if you live to 100, your year before you're 100 is shit. You know what I mean? Like, it's unusual for someone just die in their sleep. They were well and they died. Typically, it's an event. Like, if you are older than 75 and you have a neck or femur fracture, you break your hip, your chance of dying in the next 12 months is 50%.
Yeah.
Like, it's, you know what I mean? Everything, you've seen them. People get frail, they fall more, they don't eat as much, they don't sleep well. And they're in pain, right? And their physiological reserve is limited. And so once that limit has been reached, they're done. It's super interesting. Yeah, I think you go along, you get hit, you drop a level. It's very difficult to return to the same function you were unless your function beforehand was quite good. And you're very, it takes a year to recover a lot of this stuff. And you have to be quite vigilant to work for a year to get back to where you were.
Yeah.
Most people, like you were saying, are after function. And then, you have another insult and you drop down another 10%.
Yeah.
And when you get to the 50%, you're pretty shit. And you're in an early, So you deteriorate quickly. So the last couple of years of life is where a lot of our health budget's spent.
Interesting.
Yeah.
I was going to ask, to mitigate that, one, having a higher starting point. So when the hit happens, you fall not quite as far, and you got a long way to go before it really starts to compromise your life.
Which is a Attia's philosophy, right? That's what it's all about. Maintain. So project what you want to do at 70. It's very difficult, isn't it? Like, humans are the only species that can plan in advance. But to say, I want to lift my grandkids at 70 and be strong and whatever, it's like, it's a nice idea. But, most people are just trying to get through day to day.
Yeah.
But again, it's just these habits, these good habits you're forming early on. And just sort of got to stick to it. Yeah. Like, we talk about a lot. It's just showing up.
Totally, right.
Is the key.
And it's there's so many layers to it. I mean, it's a psychological thing, I think, primarily. And do you identify a certain way? Which is probably, if I could change anything, in that context, it'd be people's perception of, no matter where you are socioeconomically, it's okay to go for a run. And the amount of guys I know my age who go, no, I'm not into that, mate. I'm not into that shit.
Yeah, I'm not into shit.
And that's right. And it's like, well, mate, do it in a baggy shirt and nothing sexy about it, but just move yourself,
get
please.
out.
Do something.
I harass the elderly. Like, I'm annoying. They'll say, I was lawn bowling last year, but I've stopped. And you ask them why, and they're like, it's because I'm old. I'm like, no, it's not because you're old. What actually? And you try and break down the actual, the barriers to why they're doing it. Someone doesn't give them a lift anymore. It's a classic thing.
Totally.
But we know that if you can convince a friend to join you in doing something, there's no question that is a powerful tool. Doing it by yourself.
I do it, mate. I mean, I've said it on this podcast. I did get a group of boys on a Sunday morning to lift weights and do a very hard conditioning session. Another group of mates to come and run on Saturday morning. Monday night's primal, and I have to do it because people pay me to be there to do it. Like, I just love it. But I have to hack my way into my adherence.
Yeah, exactly. Yeah, that's right. And so, you have the ability to do it. There's a classic study in the UK where they looked at elderly people for hip surgery and hip and knee surgery, major hip and knee surgery. And they paid money for prehab, so 3 sessions a week at a gym. And they looked at the outcome. The compliance was 5%, right? 6 weeks before. So they said, okay, and this woman, she's Delvine, she's fantastic. So she bought a bus. So, in America, in UK, they've got their like counties that provide. They bought a bus. They bought a gym. They worked out where people lived. On the days they go around and pick up 20 people, 15 people, what it was, took them to the gym. Once they formed these collectives, they all did it. Complication rate dropped by 50%. Compliance went up to 75%.
Jesus.
It's just a beautiful thing. Like, you've got to do things in numbers, unfortunately.
Totally. I mean, we're a species of connection, right?
Yeah.
And using movement, and in its own right, I've seen it multiple times. You want to, connect people really well. There's kind of two rules in the sporting sense.
Yeah.
Either make the team do something really bloody hard together, like long and hard, and everybody wants to quit, but they drag each other through.
Yeah.
Or, go out and get on the piss.
Yeah, that's right. Yeah,
It's just such a funny thing. And I like to use the idea of the hard stuff more so. I think we get better from performance training, sport, team outcome. Use that first and then celebrate if you want to have the social connection, but not good from a performance metric.
No.
Too much.
Yeah, it's interesting. So you got to form those communities. Like I'd not been, so I started here a couple of years ago. I'd not been to a gym ever before.
Yeah,
ever.
right.
Yeah. In our generation, the gyms just weren't, or, a thing that you went to hang out with the bros, but it wasn't really for, strength and fitness.
And an everyday thing that you do, you're either a big muscly dude or you did some aerobic stuff or
Yeah,
you
exactly.
did nothing.
Yeah, exactly. Yeah, exactly right. And coming here, I was a bit reluctant and a bit dubious, but, the friendships and stuff you form is, I must admit, it's very effective.
There you go. So there's method in the madness.
Yeah, that's right.
If we stay on anaesthetics a little bit longer, we've spoken about a term, anaesthetic fitness, and I guess we're probably going to be reiterating some points here, but if you were to give that an actual definition, what does it mean in a practical sense, particularly when someone's preparing for surgery or anaesthesia?
Yeah, so it is quantified. So there's metabolic equivalence, which is, 1 met's staying still, and then like running a race is 8 to 10 mets type thing, which is calculated in mils per kilo per minute, like your VO2 max stuff. So you need a minimum of somewhere about 12 mils per kilo, so not much for major surgery to survive it.
Wow.
Right. So the average guy's 30 mils per kilo. The guys who do Tour de France are 80 mils per kilo, something like it's crazy. So the MET, you need to be at least 4 MET to get through an operation, right? Not to be optimized. So 4 METs is equivalent to walking up a couple of flights of stairs or pushing a lawnmower around. So it's low yield stuff. So these days you don't have to be that fit to get through, survive an operation. But to do well, you want to be as fit as you possibly can.
Yeah, really well prepared for it. If you were, someone's got 4 to 12 weeks pre their surgery, you're probably going to say this depends, but would you rather them lift weights and do some strength stuff or really hammer some aerobic metabolic fitness?
I think the cardiovascular stuff's where it's at. That has been shown to... It's interesting, the weight, the strengthening hasn't really been... It's a new thing. Yeah. It really is a new thing, relatively speaking. And to translate that into risk, I don't think it has been done, not that I've seen. I go to these perioperative meetings every year. People haven't talked about it yet. But they've talked a lot about getting cardiorespiratory is where it's at. Pumping oxygen around your body and so your heart doesn't stop. And that when you're breathing, you're exchanging oxygen for carbon dioxide and those basic stuff. Aerobically, so just 2 sessions a week, the more the better for sure. And I think this idea of NEAT, which is also relatively new, just being active, walking, dropping off, immune vascular health, which is a new thing, so endothelial health, so you get better nitric oxide release, hence the reduction in DVTs.
Which then is vasodilation.
Yeah, exactly,
and oxygen, any other blood chemistry transport.
Utilisation, and just the idea of wound healing, reduce your wound healing. So this, I think, aerobic plus active. If you can throw in some strengthening stuff, it's good. I think the strengthening stuff is good because you're less likely to go in a catabolic state, which is this idea of insulin resistance. Insulin resistance is a term thrown around a lot. It's the best way to describe it is if I inject you some sugar and I watch what your insulin does. Ideally, your sugar will peak, your insulin will peak, and your insulin drops off because it's packaged the sugar into your cells, into your body. Insulin resistance, where the insulin plateaus because it's just not able to do its job effectively. And that's sort of what type 2 diabetes is.
Yep.
So assuming you've got enough insulin, then it should be working well. So the more catabolic you are, so if you have got more muscle, you'll definitely have better insulin resistance in the perioperative period. Yeah, for sure.
Yeah. And we spoke about it on the episode with Hannah, but people post-surgery, particularly, your sort of musculoskeletal type issues, they need to eat more.
Yeah.
They need to be able to make uses of those exact processes from a recovery perspective. Same rules apply for, sort of more organ-based type things?
Yeah, same stuff. Yeah, you need to be... Most people do not utilise a dietitian pre-op. to get any of this advice. It's all just comes off. And we give advice which is hopeless, like we don't know, realistically.
Yeah.
And we especially don't optimize to people. It's like, whatever.
Yeah.
Like in terms of the carb, I mean, it's all mixed up, isn't it, these days? But, have a balanced meal, whatever that is in your idea of a balanced meal.
Mm.
But we definitely don't promote keto or carnivore or, it's just pretty standard stuff.
By the sounds of things, the masses don't need anything extreme. They just need the basics done well.
Yeah. Stay away from processed foods. Eat as much whole food as you can.
Yeah.
Stop eating when you're full.
Some
basic stuff.
Yeah. Move a little bit more.
Move more. Sleep well.
Mate, it's probably a nice note just to kind of bring it home on. I think it's as we sort of spoke about, the whole reason for doing this is I guess give people a bit more access and an insight into the medical end. As you said, most people don't even know what anaesthetics is or what an anaesthetist does for them in their health. At some point, everyone's going to have a major surgery. Yeah, it's really important to understand that, and then it's having these considerations to bookend these major, I guess, moments in people's life, which is it's incredibly valuable. But yeah, I guess to knock it on the head, to bring it home, if we were to sort of pick a start, a during and immediate post-recovery, and then in terms of the long-term for people, to I guess, provide advice as an anaesthetist, what would you really say to them? They're in that phase of the mental health, teenage type years, and they're going into this preventative mechanism. First and foremost, is it exercise? Is it food? Is it both? What is it? What is it sort of comes to mind?
Yeah, I think I tell people to prepare for surgery like you're preparing for a race, like it's literally a race. You want to be as fit and as good as you possibly can be. And so I think the combination of being physiologically strong and mentally prepared by getting as much advice you can around the surgery. And that includes what do you do beforehand, what's the surgery entail, and what is the process afterwards. A lot of people are sort of dumbified by what they have to do afterwards. They just haven't thought about it. They haven't told work, they haven't got someone at home to care for them. Yeah. They haven't considered they're going to be, have a disability for a short period of time, all those things. So you just got, there's heaps of information around, like go to good sources. And, clearly ask the surgeon, they've got heaps of advice these days, but ring the anaesthetist, involve the anaesthetist, they're going to hate me for it, but ring the officers and ask them to have a chat. Yeah. And I think having a chat with people individually, I clearly can't speak for everyone, but
makes a difference.
So be physiologically prepared and have information around the area so you feel mentally prepared as well.
And then post, as you said, have things in place where you can be taken care of for a period of time.
And, don't exclude that a complication is not for you. Like you look at drivers, you ask them, are they better than average? And most people say they're better than average drivers. Clearly most of us are average drivers. And it's the same thing, that people just don't think they're going to get any complications. So have that in the back of your mind in terms of if I was to get a complication, what impact is going to have on me post-op. And that's a key thing, I think.
Beauty. Well, mate, that's I think that's invaluable. It's we've spoken about it, closing that loop for general public and the health conscious as well. And then even those that aren't, at the end of the day, this is going to be a part of their life and we need to have an understanding of it. So I appreciate your time and open book. And man, I think there's going to be plenty more questions and things we want to ask. One fun one I'm going to give you. If you were to think of one question in terms of like a PhD style, we need to research this, that you won't have capacity for, I don't want to give away all your great thoughts or ideas. There's probably a listener out there that's into research, be it medical, be it exercise, or be it a combination of both. What's one question you'd love answered from an anaesthetic perspective so that it could, help improve?
With AI around the corner, there's this idea of customized anaesthesia. So doing the genetics to work out, because you can now do pharmacogenetics, so how your genes respond to the drugs you're getting. And there's CNS genetics to see how you respond to anaesthetic agents. So it'd be wild to have a drop of blood come out with a pharmacogenetic and a neural profile to tell the anaesthetist or the machine or whoever's going to do it what to give you perfectly. That'd be amazing.
So someone's going to go and find out that answer.
Yeah, that's right. Beauty. Good luck.
All right, I love it. Conrad, thanks very much for your time.
Cheers, mate. That's great. Thanks, good.
Thanks for tuning in to the Science of Fitness podcast. Be sure to check us out across all forms of social media and subscribe to this channel if you want to stay up to date to the latest episodes and any other anecdotes with which we might share across these video platforms. If you ever find yourself locally in Brisbane, be sure to drop into one of our facilities or down on the Gold Coast in Burleigh. You can also check us out at scienceoffitness.com.au and see all things relating to what we offer in programming and performance, whether it's online or in person.